Welcome everybody. We'll just give a couple of moments for people to join. You're very welcome to the final webinar of this year. And it's going to be delivered this evening by the NCCP on non-specific symptoms of cancer. My name is Michelle and I'll be facilitating this evening. So just to go through the usual domestics, this webinar is being recorded for your information. The playback will be available by the end of the week online. For anybody who maybe registered and couldn't make it, or for anyone who missed the registration details. We'd advise you to keep your microphones muted if possible, and that's just to improve the sound quality. Your videos you can keep on or off as you wish. It's always lovely to see the faces of people who have joined, but particularly if you're experiencing problems with connectivity, try turning it off and that should help with the issue. If you're having difficulty with sound, you can check whether the sound or speaker is muted or turned down. Failing that, then try logging off and back on again, and usually that works. And we have the chat box open for questions or comments, so feel free as the questions arise in your heads to pop them into the chat box. I'll be keeping an eye on that, and at the end of the session we'll kind of compile some of those common questions with the time at the end. And just to note, we will be using some anonymous information from the webinar. So to introduce you to our two presenters, first of all, we're going to have Margaret Triggs, and Margaret is the Chief 2 Pharmacist at the Cancer Drug Management Programme in the NCCP. She's previously worked as a hospital pharmacist in cancer services in Beaumont Hospital, the Mater Private Hospital, and CHI at Crumlin, and she joined the NCCP earlier this year. And then Margaret will be followed by Dr. Una Kennedy, and Una is a GP in Dublin and GP advisor to the National Cancer Control Programme. Her areas of interest are cancer prevention and early diagnosis of cancer. So with that, I'll hand you over to Margaret to begin the session.
Great, thanks, Michelle. So yeah, thank you and welcome everybody to the webinar, and we're delighted to be hosting the final IOP webinar of the year. And again, thanks to you all for taking the time out to attend, because we obviously know it's an extremely busy time of the year. So the main content of the webinar will be delivered by my colleague, Dr. Una Kennedy, who has a really fantastic presentation from you. But I just have a few brief slides just to, I suppose, flag to you some of the resources that we have in the NCCP and that the pharmacists within NCCP are involved in developing. So we can go on to the next slide, please, Grace. Thank you. So I suppose just as lots of sections within the NCCP, and the pharmacists within the NCCP work within the systemic therapy programme. So that programme is actually responsible for overseeing the national services for the treatment of cancer with systemic anti-cancer therapy, or SACT. And that slide just has a brief list of some of the things we're involved in. I suppose the main focus of the NCCP is really to implement the recommendations of the National Cancer Strategy, and we're obviously on our third cancer strategy at the moment until 2026. And the recommendations from those cancer strategies inform the majority of our work. A large portion of our work is around regimen development, which I'll talk about on the next slide, but we're also involved in the preparation of guidance documents. Some of the main ones are in the screenshot there on the slide. I suppose many of them are hospital-based, but there are lots that would be of interest maybe to community pharmacists as well. Some of the main ones are just listed in the slide there, and one in particular, which is important, is the SACT model of care, which was published last year. And that was a huge piece of work completed by my colleagues, and really that provides a roadmap for the continued development of SACT services across Ireland into the future, and obviously considers the likely change in demographics and also the change in incidence rates for cancer, and also I suppose takes into account the number of patients that will likely need SACT treatment going into the future. Something else we're involved in is the NCCP Technology Review Committee, and those meetings, the minutes of those meetings are actually available on the website if anybody's interested to have a look. So I suppose that committee really formally adds the voice of the cancer clinician into the HSE reimbursement assessment process. So that's a really important piece of work. We're also involved in workforce planning and service planning, I suppose mainly at hospital level, also in education. Additionally, in molecular diagnostics, and I suppose that the work there is really in ensuring that the appropriate testing platforms are in place for any new cancer treatments which are coming through, because I suppose sometimes you need to have a particular level of a biomarker expression on your tumour to be suitable for a cancer treatment. So we need to ensure that testing is in place when those new treatments are available. And NSIS as well, or the National Cancer Information System, falls under the systemic therapy program. And this really is an e-health program, and it records information about a patient's cancer case, their diagnosis, and their treatment record. It's all recorded electronically in one place, and that system's due to be rolled out in the 26 public hospitals who deliver SACT, and it's now live in 16 of those hospitals, which is great. So I'll just have the next slide, please, Grace. So just to move on to regimens, so hopefully many of you are aware of these already, and I know these will have been flagged by my colleagues in previous webinars. So obviously the pharmacists within NCCP are involved in developing these regimens. They're all readily available on the NCCP website under the healthcare professionals page. They're a key enabler of the safe and quality treatment of patients with SACT. And I suppose just to talk about that term, you'll increasingly see that term used instead of chemotherapy, because as you all know, the cancer treatments have grown and expanded, and now we now treat cancer obviously with hormone therapy, targeted therapy, and immunotherapy, as well as traditional cytotoxic agents. So SACT is the catch-all term that's used to encompass all of those treatments. The regimens will support the safe evidence-based treatment as well with SACT, and you'll see the clinical trials which inform those treatments listed in the reference section of all of the regimens. The regimens, just as important to say, they don't direct care. They're not intended to direct care. So the primary consultant, say the oncologist or the hematologist, will still determine the best treatment for those patients who require treatment. They follow a standard format, so you'll see the same sections within each. We have a large number of them on the website at the moment, over 480, and they are included in those are regimens for oral anti-cancer medicines, or OAMs, and the majority of which are obviously dispensed in the community setting. So the regimens are listed on the webpage by tumour site, but we do have an OAM, or an oral anti-cancer medicines page, which lists all of those regimens together regardless of tumour site, which is hopefully convenient for you to find them. We have a robust development approval process around those regimens. We work with practicing consultants as lead reviewers on these, and sometimes other healthcare professionals are involved, maybe hospital pharmacists or sometimes nurses, and we'll always try to have a regimen ready to upload onto the website when we get confirmation that any new drug is reimbursed, and that's really to support the timely access for patients to new treatments. So the next resource I just want to flag to you is the community pharmacist resource page. And I suppose obviously there's a role for pharmacists to support cancer patients in both hospital and community, and essentially across the whole cancer care continuum, right through from prevention to treatment and management of side effects. And we've prepared this page, I suppose, to be retargeted at community pharmacy, and it has a particular focus on safe dispensing of oral anti-cancer medicines, patient counselling, and also around supportive care for systemic anti-cancer therapy. So there's lots of useful information hopefully on that webpage. Maybe there's links to patient information leaflets, links to other websites which might be helpful, supportive care guidelines, links to our own guidelines around antiemetics. There's links to drug interaction checkers. So if you have particular interest in an area or a query from a patient, hopefully you'll find something on there which will be helpful. Our contact email is on the end of that page as well. It's oncology-drugs@cancercontrol.ie. It's on the first slide that I had as well. So if you see anything that you would like to give feedback on, we're very happy to take your feedback in terms of either regimens or that community pharmacy resource page. And just I have two little snips there on the slide on the bottom left, is just to show you, I suppose, the front page of one of the regimens, which has a treatment table there, which shows the schedule of treatments. And then in the blue box is just the list of the sections that are in all the regimens. So just hopefully because they're formatted in the same way, it would be easy to find the information that you require on them. And I should also mention that my colleagues did a webinar last year on the care of the cancer patient in the community, which went into a lot of detail regarding supportive care, and that's obviously still on the IOP website if anybody wants further information on that. So I just have a couple of more slides just to flag one other development, and I possibly don't even need this slide, but I don't really have to tell you this. I suppose that you're a very trusted profession and you're extremely accessible to patients, and we've got surveys, I suppose, listed there which highlight that information. And I suppose on the next slide, we're just stating really that we know community pharmacists have a significant role in cancer care, and that role is really evolving due to the increased use of SACT, I suppose the increased prevalence and the increased use of oral anti-cancer medicines. And really, I suppose, as a result of the frequent interactions and the strong relationships with patients, pharmacists and pharmacy staff are in an excellent position to support patients to reduce their risk of cancer, to identify signs and symptoms suspicious for cancer, which is obviously the topic of this webinar, and also to support patients living with and beyond cancer. So research has shown that community pharmacists would welcome an increased educational support on the topic of cancer. And I suppose research was carried out earlier this year in the form of focus groups, which were facilitated by Red C, that happened in May of this year. Some of you may have been involved in those. And I suppose the culmination of all of that is that we have a proposal now to support community pharmacists by providing a cancer care champion resource. And just on the next slide, it's just to really flag to you that we've already started some work in this area, and we are looking to develop a cancer care champion pharmacist resource, which would be an education resource for pharmacists to enable them to enhance the care they provide for the general public and for patients with cancer. And it's in the very early stages of development, but we are working with the IOP on this, and we hope to be coming back to you next year with an update on this project. We'd envisaged initially that it would be a resource and a hub for information relating to aspects of cancer care, but we'd love to see it evolve into something more than that. But as I said, we'll be back to you hopefully next year on this. And then just to say, I suppose we're hoping that's fulfilling an identified need, which is great. And just, I suppose, also on the slide, just to show that it actually fits in with the recommendations from some of the national documents, I suppose, listed there. And that's it for me. So I can hand over to Una now, who has a really excellent presentation on the non-specific signs of cancer. And I know you'll all find it very useful, because I will as well. So thanks very much.
Okay, Margaret, thanks very much. That was really excellent. There was loads of information there. I think people will find that very useful. Thank you very much. You're a hard act to follow. And thanks again to Grace and Audrey for having us here, and to everyone for turning out on a winter's evening. It's really great that people have turned up this evening, because I'm sure you're all very busy. So I'm going to speak about the non-specific symptoms of cancer. If the next slide, please. And I'll very briefly talk about what the National Cancer Control Programme is and what it does, because people don't always know. As Margaret said, we're currently on our third National Cancer Strategy. That'll bring us up to 2026. Each strategy is 10 years long, so we've had 3 decades now almost of cancer strategy. The second one stipulated that there should be a cancer control programme, and it's an office basically in Parnell Street in town, where you have the pharmacy group with Margaret and those like her working away on the pharmacy side of things. There's a survivorship group, there's an early detection and prevention group. And this is what we do. We try to prevent cancer where we can, diagnose it as early as possible where it can't be prevented, treat it as successfully as possible, with the hope of increasing the survival and improving the quality of life for people who do develop cancer in the end. And as Margaret was saying, in one word, you'd say it's the strategy. That's our main job, is we implement most of the recommendations of the National Cancer Strategy. So the next slide, please, Grace. And where some of you know, I mean, maybe not so much pharmacists, but certainly GPs and practice nurses would know, is from the cancer centres. But these are important to know about. There are 8 cancer centres around Ireland, 4 in Dublin, James's Mater, Beaumont and Vincent's, 4 outside of Dublin, Cork, Galway, Limerick and Waterford. And for some of the commonest cancers, we can send people into these centres. So you can see on the top left there, lung, breast, prostate. Those would be 3 of the commonest cancers in this country. If someone comes into me with something, symptom or sign suspicious for, say, breast cancer, I can fill out the electronic form, and I often will, as they're sitting in front of me, send it directly up to the local hospital. They'll have it right away. And that person will be seen in the breast clinic within 2 weeks, within 10 working days. After that visit at the clinic, they will have their mammogram, their ultrasound, their biopsy, and they'll be called back about a week later for their results. And the reason I'm labouring this is because you'll often hear it said, oh, sure, I'll never get seen, sure, they'll never get around to me, I'll be waiting forever. I imagine the community pharmacists will hear that a lot. And it's not true, not for cancer. You will get seen quickly. So it really is important to get in to get seen quickly. Next slide, please. I'm going to talk next about the cancer epidemiology in Ireland, the state of play at the moment for Ireland and cancer. So at the moment, we have 24,000 new cases of invasive cancer every year. Now you see in brackets there, excluding NMSC, that's non-melanoma skin cancer. Every year we'd have about 20,000 non-melanoma skin cancers. They're malignancies, but they're fairly fairly kind of benign in their behavior. So they tend not to be fatal And there's a huge number of them, and they skew the figures. So it's kind of an international convention that you exclude them from your numbers because they can really skew your numbers. So we have 24,000 cases for all intents and purposes every year. We have considerably fewer than that, thankfully, dying from cancer, 9,000 people dying from cancer every year in Ireland, but that still means one person every hour, every day. We know that 1 in 2 of us will get cancer at some stage in our lifetime in Ireland. So it's either going to be us on this call at the moment or somebody very close to us. You know, we're all going to get touched by this one way or the other. And we know now that cancer is the #1 cause of mortality in Ireland. In 2018, it overtook cardiovascular disease as our single greatest cause of mortality. But at the end there is light at the end of the tunnel. We now have more cancer survivors in this country than we ever had. The NCRI report came out in November, and we have 215,000 cancer survivors in Ireland at the moment. That's 1 in 23 of us is living with a diagnosis of cancer. Now, some of that is down to the fact that so many more people are getting cancer, but some of it is genuinely down to the fact that there is better treatment and better survival. And in fact, our survival from cancer now today is 50% higher than it was a decade ago. That's 50. It's a massive, massive leap. So things are definitely improving. So if people come into you and they're very distressed and very hopeless, there is actually a lot of hope to be had. Now, this chart, some of you will have seen before. There are over 200 cancers possible in humans. It's a huge number of cancers. And there's 5 million humans on this island. So it's overwhelming. But this grey chart here, these 25 or 23 cancers, they account for 95% of all the invasive cancers you'll see in this country. So I often think if we could just get on top of these, we'd be doing really well. And it's quite heavy at the bottom here, as you can see. Prostate, breast, lung, colorectal, and melanoma. Those top 5 cancers, 4 in men, 4 in women, between them, they'll account for about 60% of all the cancers you'll see in humans in Ireland. So if we could even get on top of those 4 or 5, we'd be doing really well. Next slide, please. So, Grace. And this is what it looks like for men. So you can see that prostate is by far the commonest cancer in men in Ireland. About 1/3 of all cancers is a prostate cancer. Followed up by colorectal at 13.5, followed by lung, and then finally followed up by melanoma, skin cancer. And the next slide, please, Grace. Markedly similar picture for women, for females. So 30% of all cancers will be breast cancers. That's about 1/3, followed up by lung, then by colorectal, and then by melanoma in women. And that accounts again for almost 60% of all the cancers you'll see in females in this country. And that's the present situation for cancer. This is the future. I often think you can't predict the future, but the National Cancer Registry had a go at it all the same. And they reckon if things continue as they are, with our population expanding, growing, and aging as it is, they think that between 2015 and 2045, the number of cancers in this country will double. Now, it's not to say that there's a calamity awaiting us. It's just that there will be more people and we're all living longer. And these are all good things. But we are all going to be living long enough to get things like cancer. I suppose the good news is that up to 40 or 50% of cancers, the World Health Organization would say, can be prevented. So this doesn't have to happen. But yeah, the numbers are going to go up. The next slide, please. And now I suppose on to the meat of things this evening, the non-specific symptoms of cancer. So the next slide, please. Now, what are the non-specific symptoms of cancer? And unfortunately, I think it all gets a bit non-specific straight away here. There's no single clear, universally agreed definition of what these symptoms are. It all gets kind of fuzzy straight away. There's a few possible ways of defining them. You could say they're not site-specific. So you look at the site of a tumor, like a lump in the breast. Now, not every lump in the breast is a malignant one, but if you have a breast lump, you know, if it's a cancer, it's going to be a breast cancer. It's not going to be a lung cancer or a brain cancer. It's going to be a breast cancer, more than likely. If you have a mole on the skin that doesn't look right, that's more than likely going to be a skin cancer than any other type of cancer. It's specific to that site. And non-specific symptoms are not specific to any site. They could also be considered low risk, but not no risk symptoms. That could be cancer, but probably aren't. And I often think of cough as being this sort of a symptom where cough is the commonest presenting symptom for lung cancer. But I mean, 5% of all the people GPs see every year would be respiratory. That's a whole load of people with coughs and splutters. They don't all have cancer by a long shot. Cough, yes, it might be a cancer. Of course, it could be, but very likely it won't be. It's a low risk, but not no risk symptom. And this is probably the most useful. I don't know how familiar pharmacists are with NICE guidelines. Do pharmacists use NICE guidelines much? But in the United Kingdom, they have NICE guidelines. And they have a list of symptoms that should trigger an urgent referral for cancer. And the example would be a breast lump. If somebody comes in with a breast lump, that triggers an urgent referral. If somebody comes in and they're coughing up blood, that triggers an urgent referral. And non-specific symptoms would be symptoms that don't trigger an urgent referral under the NICE guidelines. And examples would be weight loss, fatigue. I mean, fatigue is really vague. We're all fatigued. Or off form, just off form could be a non-specific symptom. Next slide, please, Grace. Thanks. So why are they a problem? This is why they're a problem. I mean, under the NICE guidelines, they have a list of symptoms that would trigger urgent referral for cancer. But what they found was that those guidelines are only picking up half their cancer cases. So half of people will present with non-specific symptoms. And we know that 50% of people in Ireland will get cancer at some point. And we know that half of those people with cancer will present with non-specific symptoms. So it is a really big problem. The next slide, please. And this is why they're our problem. Well, 92% of people diagnosed with cancer will begin their cancer journey in primary care or general practice. So they're going to begin by pitching up in front of their GP or their public health nurse or the practice nurse or indeed their pharmacist. Next slide, please. Grace, thank you. And in terms of hard numbers, I think this is what it will look like for Ireland. If we imagine that we've 24,000 cases every year, we imagine then that 90% of them, 22,000 will begin in primary care. So 11,000 people will present with non-specific symptoms, vague feelings like being off form, being a little bit tired, having lost a little bit of weight, just not right, all a bit vague, very, very difficult to spot. Next slide, please. And why does it matter if people present like this? And this is why it matters. There's a lot of international evidence out there that people with non-specific signs and symptoms of cancer just don't do very well. They have a longer diagnostic process. It just takes longer for them to get to a diagnosis because, and I would see this at work, you just don't know where to start with them sometimes or where you're going. It's just not obvious. They're more likely to present in the first place with late stage disease. So they might be off form for a while. They might have lost a bit of weight for a while. They mightn't be eating very well for a while. Their tummy might be a bit off. And it doesn't even register with them that there might be a problem until a bit late in the day. They wind up then being more likely to be diagnosed in an emergency setting. They end up being rushed into the casualty departments. And it's not that they do anything terrible to people in casualty departments, but if something happens that drives you into emergency late at night and you cannot possibly wait till the morning, that has to be something fairly serious. And that's not a good place to start your cancer treatment. And then as a result of all of that, they tend to have poorer outcomes. This is why it matters. I thought a slide like this might appeal to pharmacists. You're going to love the table of numbers, I hope. This is from the Lancet Oncology in 2020. And they did a modelling. Now, it's not a real study, it's just a model. And they were thinking about in terms of COVID, of what would happen to cancer patients' life expectancy if their diagnosis was delayed by 3 months. So if you click again, please, Grace. Yeah, so if you look at the age groups here, so look at the age group 30 to 39. If their diagnosis is delayed by 3 months, their 10-year life expectancy drops by 16.87%. And click again, please, there, Grace. The group 40 to 49, if their diagnosis is delayed by 3 months, they have an 18.26% drop in their 10-year life expectancy. Almost every cancer on that screen will suffer a drop of 10%, at least 10% in their life expectancy if their diagnosis is delayed. Next slide, please. And this is what I suppose a late stage diagnosis looks like in Ireland. These are Irish numbers. So the 5-year survival is a convention. People are living a lot longer than that with cancer nowadays, but it's a fairly internationally held convention. We talk about 5-year survival. Cancer, as you all know, broadly speaking, has 4 stages. Stage 1 being very early stage cancer, and stage 4 being the late stage cancer. And this chart shows our survival for early stage cancer compared to late stage cancer for the 5 commonest cancer types in this country: breast, prostate, lung, bowel, and melanoma. And what you can see here straight away is that survival, if you're diagnosed at stage 1, is actually really good. If you're picked up with melanoma skin cancer at stage 1, your survival is 100%. It drops to 32% if you're picked up at stage 4. If you're diagnosed with prostate cancer at stage 1, it's 100% survival. You'll be fine. But that drops to 53% at stage 4. Bowel, granted, maybe not so good. It's a 97% survival at stage 1, but still very good. And then it really just collapses down to 14% at stage 4. Breast, and 99%. This is the commonest cancer of women. 99% survival if you're picked up at stage 1, falls to 34% at stage 4. So people with any signs or symptoms, they just have to get in as quickly as they can. Granted, now lung just doesn't do as well as the others. It's a fairly poor 5-year survival of 57%, but again, it drops to just 4% survival if you're diagnosed late stage. So it really does matter. And I just want to go through these clinics again. Here they are again: James's, Mater, Beaumont and Vincent's in Dublin, Cork, Galway, Limerick and Waterford outside of Dublin. And if you have signs or symptoms of lung, breast and prostate cancer, you go into your GP, they refer you electronically, you will be seen within a couple of weeks. So it's really important to get in quickly. For the other 2 common ones, for melanoma skin cancer, there are pigmented lesion clinics scattered around the country. There's about 20 of them, I think. And again, I can refer electronically to a pigmented lesion clinic. They are seeing people within about 4 weeks on average. For bowel cancer, we have electronic referral for bowel cancer as well. You can go straight to endoscopy. You don't have to go to the outpatients. And again, the waiting time target there is 12 weeks. I won't say they always make it, but they're making it a lot of the time. So people will get seen quickly if they have worrying symptoms. The next slide, please. I'm just watching the time. So what I've done on this chart, I've taken those 5 cancers again, and I've just shown the percentage survival if you're picked up at stage 1 in the green bars. And then beside that, I've shown the percentage of people who are diagnosed at stage 1. So our melanoma people, if you're picked up at stage 1, you'll have 100% survival, but just 63% of people are picked up at stage 1. For prostate, 100% survival if you're picked up at stage 1, but 45% picked up at stage 1. Bowel, 97% survival if you're picked up at stage 1, just 17% are picked up at stage 1. That really needs to change. We really need to work on that. Breast, again, lots of room for improvement. 36% of people are picked up at stage 1, but if you are found in that stage, you have a 99% survival. And then for lung, it's coming in last, unfortunately. 57% survival if you're picked up at stage 1, and 21% of people are picked up at that stage. So there's room for improvement there for sure. The next slide, please. So what can we do about this half of people with cancer who will present with non-specific symptoms? We suggest these 2 approaches: praise the patient and appraise the symptoms. And if you click onto the next slide, please. So this is what we mean by appraising the patient. Cancer can happen to anyone at any age, and we've all been caught out by people who've had cancer at a very early age that floors you. But some risk factors can place you at an increased risk compared to other people. And we divide the risk factors into non-modifiable and modifiable. So non-modifiable would be the ones that you can't change. That would be your age, your family history. And modifiable would be the ones that you can change. So you can change whether you smoke, you can change whether you expose your skin to the sun, or how much alcohol you consume, and so forth. Next slide, please. So the non-modifiable risk factors, what are they? The biggest one is old age. Now, be careful. Anybody can get cancer at any age, but age and increasing age is the single biggest risk factors for cancer. And 86% of our cancers will happen in people over the age of 50. Now look, about 25% of melanomas happen in people under 50, about 25% of breast cancers happen in people under 50, 10% of bowel cancers in people under 50. So it can happen to anybody, but age is the big risk factor. Genetics and family history come in next, and your most cancers are just random, but 5 to 10% are caused by inherited gene variants. Your past medical history, you can't change that. So some medical conditions increase your risk. So for example, if you have inflammatory bowel disease, particularly if it's extensive and severe, or if you had it beginning in childhood, that can increase your risk of colon cancer. COPD, that's smoker's lung disease, that can increase your risk of lung cancer. People with COPD, it increases their risk of lung cancer by about 3 to 5 times. And then socioeconomic deprivation is strongly associated with an increased cancer risk. So cancer incidence in people living in deprived areas, it's 7% higher in males and 5% higher in females compared to those living in the least deprived areas. Particularly, you're looking at stomach, lung, and cervical cancer. Thanks, Grace. The next slide, please. So those would be your non-modifiable risk factors, the things that you can't change. So, we're looking out for older people, anybody who has a history of certain illnesses, or you might know their family history, or people who might be deprived. The modifiable risk factors, the things that we are doing that we could possibly change. So the next slide, please. And it's a little tongue-in-cheek, but this chart here is from the National Cancer Registry again, and they had a go at figuring out how many cancers are caused in Ireland each year by the particular risk factor. And again, not surprisingly, smoking tops the league, almost 3,000 cancers every year, 13% of all our cancers. Overweight and obesity, just over 1,000 cancers. Infection, there you're talking about HIV, hepatitis B, human papillomavirus. Now, you won't always know that somebody has hepatitis B. You may know somebody has HIV, they may be on certain medications. One thing I would say to you about the human papillomavirus is that we now think that we are going to eradicate or eliminate cervical cancer in Ireland. In fact, the plan is it will be eliminated in 17 years. By 2040, the cervical cancer will be eliminated in Ireland. If we keep vaccinating and keep doing smear tests the rate we're going, we'll get there. And I would just say that one of the strongest motivators to vaccinate is advice and positivity from a trusted healthcare professional. So I would appeal to you, if somebody is asking you about the HPV vaccine, to nod your head vigorously and to encourage it, because it's a really exciting thing that we might be able to eliminate cervical cancer. Alcohol causes a fair few cancers, and sunburn, sunbed exposure. We'll press on, please, Grace. The next slide, please. I'll run down through them a little, the modifiable risk factors. So smoking is the biggest, the single greatest modifiable risk factor. If we stopped smoking, we would drop our cancer cases by 2,700 or more. So it causes a huge proportion of lung, larynx, and bladder cancers, 76% of our lung cancers, and that works out at 2,030 cases. And if you click again there, Grace, please, you can just see the survival again, the 5-year survival for lung cancer. It's the poorest of the common cancers, and it's a difficult cancer to treat and to fix, but the answer is to just not get lung cancer, to stop smoking, or encourage people to quit whenever you can. The next slide, please, Grace. I couldn't resist putting this up. There are lots of things out there to help people quit. There's quit.ie. They can free text quit to 50100. And again, I can refer people electronically to smoking cessation advisors, where they will get counselling and they'll get nicotine replacement therapy free of charge. So by all means, encourage people to get in to me to get help to quit. Next slide, please. Overweight and obesity, it's the second one on the list from the NCRI. This is what it is. Overweight is a body mass index between 25 and 29.9. Obese, a body mass index greater than 30. And it can contribute to a significant number of cancers, esophagus, breast, bowel, pancreas, ovary, or uterus myeloma. It's thought to contribute to about 1/3 of cancers of the womb. And it's the estrogen in the adipose tissue that promotes growth of the lining of the womb, and overgrowth of that lining can predispose you to cancer of the womb. It's difficult to lose weight, but again, every opportunity needs to be taken to encourage people to lose weight or at least to maintain their weight. And it's difficult to do, but it's one of those things that we need to approach in a respectful way, have a respectful conversation about it. Alcohol, please. Sorry, the next one. Sorry, next slide, please, Grace. Yeah, alcohol, again, it's another thing we kind of need to have a conversation about. 500 cases of cancer annually, they reckon, in Ireland. It doesn't account for a huge proportion of breast cancers, but because breast cancer is so common, just 7.5% of female breast cancers is a significant enough number of cancers. Unfortunately, with alcohol, there is no safe level of alcohol when it comes to cancer. Your risk increases the more alcohol you consume, and the only safe level is 0. And it's impossible to look at somebody and say, oh, well, your cancer was caused by alcohol, but yours wasn't. You can't do that. The next slide, please. Again, what's a drink? It's really difficult to know what a drink is in this country. You know, big glasses of wine and small glasses of wine. Women are recommended to have no more than 11 standard drinks, and men no more than 17 standard drinks. And I think the easiest way to remember really is your average bottle of wine has 7 standard drinks. So if you get through a bottle of wine, certainly as a female, you're well on your way to your limit for the week. The next slide, please. And just a quick recap. Those are the sort of risk factors you're looking at. So we talk about appraising the patients. There's the modifiable risk factors and the non-modifiable. The next slide, please, Grace. Here they are summarized in front of you. So older age, male or female, anybody with a family history that you might or might not know about, a health history that you might or might not know about, and socioeconomic deprivation. Other factors would be the smoking, alcohol, overweight and obesity, sun exposure. Now, you might know somebody's using sunbeds, but you might know that somebody is an outdoor worker, for example, and infection. Like I say, you might know that they have hepatitis B, but you might know that they have HIV, for example. The next slide, please. The next step is to appraise the symptoms. The next slide, please. So before I just go on, I'm going to talk about gut feeling. This is research done on GPs. I suspect it applies to pharmacists. I'm sure it does, and to nurses as well, practice nurses. There's a lot of evidence out there to say that gut feeling is a very powerful diagnostic tool. So what is your gut instinct? It's the sum of all your knowledge, all your experience, and all your knowing from reading and courses and being educated. It's everything you've learned over the years. It's everything you've learned from all the patients you've investigated, referred, or received feedback about, all those patients you meet all the time, all the things you learn just from interacting with them. And then there's your knowledge of humankind and the context, like the person and the community you work in. All of those things add up to your gut instinct. We did some research with public health nurses a while back, and a great story. Public health nurse met some guy she knew. She was going to a GAA match. She met him in the car park. She had a chat in the window of his car. And she said, right, are you coming up to see the match? And he said, I can't breathe. I'm just not able. And she said, there's something wrong with you. You have to get that checked. And he did. And he had, unfortunately, lung cancer. But she knew him. She knew the match. She knew his love of GAA. She knew the community. She knew that there was no way this guy would miss a match unless there was something wrong. And she was absolutely right about that. Next slide, please, Grace. There's evidence about it as a diagnostic tool. And again, this applies to GPs. I just haven't found anything on pharmacists. I'm sure it's there. This is a systematic review from 2020. 12 studies, they all found that gut instinct was useful. One of them found that for a GP, if a GP felt you had cancer or a serious diagnosis, there was a 10% chance or so that he was correct. So that's quite staggering. Next slide, please. What factors increase your positive predictive value of gut feeling? Experience, age, empathy, and familiarity, knowing your patient, knowing their behavior, knowing who they are. Next slide, please. Now, which symptoms are we looking? So that's your gut instinct. If something tells you that this person isn't great, that's really important to listen to that. What symptoms are we talking about? Well, in the UK, they set up 2-week weight clinics. Can you click again there, please, Grace? These are very similar to our clinics for lung, breast, prostate, where you get seen within 2 weeks. So they set those up in 2000. And they realized that they weren't picking up enough people. They were missing about half the people, and half the people have non-specific symptoms. So if you go back, please, Grace, in 2017, they set up 10 clinics around England for people with non-specific symptoms to give them rapid access to a range of tests, all in a single pathway. And the results of these were published in 2020. If you click again twice there, Grace, please. And these are the results. Now, it's a small study, just 3,000 people over a period of 18 months. Average age was 66 years. 87% were over 50, which we wouldn't be surprised at because most cancers occur in people over 50. About half male, half female. 8% were diagnosed with cancer. Doesn't sound like much. Will you click again? Just a second there, Grace, please. Those clinics, the 2-week wait clinics, they're finding that 6.8% of people who go to those clinics have cancer. So these clinics for non-specific symptoms were picking up more cancers than the other original clinics. The next slide, please. So what were people coming in with? They were coming in with weight loss, with clinical suspicion, with pain, and they don't even say what sort of pain, any pain, just pain, nausea, appetite loss, fatigue, which is extremely vague, anemia. Now, pharmacist, you're not going to have the blood test, you mightn't know that. Change in bowel habit, just a dicky tummy, somebody's tummy, and poor general condition, which, let's face it, that could mean just about anything. Next slide, please. So these are the symptoms. There's 5 symptoms in the UK that they say should merit a referral to the non-specific clinics. And these are the ones they expect people to keep an eye out for over there. So weight loss. Weight loss is a pretty hard sign. It's new, unexplained weight loss of 5% in 3 months or strong clinical suspicion. And the word here is unexplained. We had a lady some time ago with weight loss and she was being investigated up and down, and she was a lovely woman, and she sort of had a mild intellectual disability and was living in sheltered accommodation, but like very well able to mind herself and to get on and to do everything and to come and see us and to go to her appointments on her own. And one day, I don't know what I was doing, and I said, I need your list of medicines. I mean, this list I have here it's all over the place. What medicines are you on? And she didn't know. So I contacted the sheltered accommodation where she was staying. I said, look, can you send me up a list of her medication? And sure enough, she was on Ozempic. And of course, she had lost a load of weight. She was on Ozempic. So it's unexplained weight loss of 5% or more. Next is constitutional symptoms. And again, really vague: loss of appetite, fatigue, nausea, malaise, or bloating. You know, I mean, honestly, that could nearly be any one of us on any given day. But it's bloating that stays, bloating that doesn't come and go. It's present continuously. Abdominal pain, which is new, unexplained, vague abdominal pain, 4 weeks or more, or less if you just happen to be worried. And then pain generally, so new, unexplained, unexpected, or progressive pain, including bone pain for 4 weeks or more. So it's not if you fall down the stairs and sprain your ankle sort of pain that you can't understand and that just isn't going away. It's there all the time. Nighttime pain is particularly worrisome. And again, you could very easily have people coming in talking to you about aches and pains. And then finally, your gut instinct. If you have a gut instinct that there's something wrong, you know somebody, you're seeing a lot of them, and you just think, God, this isn't right, they're not right. That really is important. So the next slide, please. I couldn't resist putting them in twice just to make sure that everybody got a good look at them. Thanks, Grace. The next slide, please. So I'm just going to show you ovarian cancer, just to give an idea of how difficult it is and how vague the symptoms can be. We have about 411 cases every year, 272 deaths or thereabout. The stage of diagnosis, most of them are picked up late stage. I mean, just 32% are picked up at stage 1 or 2. So we're not doing very well there. Next slide, please. And these are the risk factors. Now, I said appraise the patient, but like the reality is here, most cases are over the age of 50. But a fair chunk of them aren't, 16% aren't, which makes it very difficult. Family history of ovarian cancer is important. Not ever having had children is important. HRTs can have a slight increase in your risk of ovarian cancer, but it's very hard to spot any useful risk factors here, I think, that you can cling on to. The symptoms that you're looking for, next slide, please. They use this mnemonic, BEAT, B-E-A-T. So B is for bloating. If you click again there, please, Grace. And you can see it matching up with the symptoms on my list from earlier. B is for bloating that doesn't come and go. E for eating. So if you're feeling full more quickly, your appetite is gone, and you're just not eating. A for abdominal or pelvic pain. And T is for toileting changes, so changes in your urine or bowel habit. Um, those are the sort of vague symptoms that you can get typically with ovarian cancer. You can have some of them, you can have all of them, maybe you won't have any of them. They're very vague, very easy to miss. The next slide, please. Now, as you can see, we don't have a rapid access clinic for ovarian cancer. So where does this person go? So your next slide, please. Well, most GPs around the country will, over time, have figured out workarounds for all of these things. Be it that we have local medical assessment units. So, for example, Bonsecourt near me in Glasnevin would have a medical assessment unit. For older people, we have Care of the Elderly Rapid Access Clinic. So anybody over 65 get referred down there, they'd be seen within 72 hours. There are ambulatory gynecology clinics where they will see people within 4 weeks of referral in the Rotunda, Holles Street, Coombe, and other gynecology centres around the country. Failing that, we can refer urgently to outpatients. Failing that, we pick up the phone and make a phone call. And I did that once, 1 year actually, Christmas Eve. I had to phone a consultant about a young man with a testicular lump. And I phoned him. I finally got the consultant around lunchtime on Christmas Eve. And he said, send him up this afternoon. I'll see him. I'll sort him out. And he did. So, you know, people will get seen quickly. If all else fails, yes, they can go down to the emergency room. So the next slide, please. So what else can you do? I mean, I wanted to talk briefly about this. I'm nearly done. You'd be glad to hear. Barriers to diagnosis. We have done some work about beliefs around cancer in the general population. And I'm very cognizant of Margaret's slide about how trusted pharmacists are amongst the population. And people will listen to you. This is what we found on the beliefs of cancer. So some of the positive beliefs. So going to the doctor as quickly as possible after noticing a symptom could increase the chances of surviving. There's a 98% agreement. That's great. Cancer can often be cured. 88.7% agreement. That's great. These days, many people with cancer can expect to continue with normal activities and responsibilities. 90.6%. Again, that's great. A lot of positivity about cancer there. You click again, please, Grace. These are the negative ones. It's a little more concerning. So most cancer treatment is worse than the cancer itself. And 61.3% of people agree with that, which is quite concerning. I would not want to know if I have cancer. And 15.2% of people agree with that. And that's a small enough number, I suppose, but it's significant enough. I mean, we've just demonstrated your chances of surviving if you picked up early. I mean, actually, you do want to know if you have cancer, and you want to know as soon as possible and get onto it. So that is worrying. And then a diagnosis of cancer is a death sentence, 28.5%, which is very worrying indeed. I mean, we've just shown 100% survival for prostate and melanoma, 97 for bowel, 99 for lung, for breast if you get in early. It's not a death sentence, not at all. Next slide, please. So about 1 in 5 people have negative beliefs, and they're more likely to be socioeconomically deprived. They're less likely to seek help from a doctor if they have cancer symptoms, less likely to seek help from a doctor first. So they may well arrive in to yourselves for a little chat, and it may well be yourselves that need to give somebody the nudge to go and get help. So please do if you can. So next slide, please. How to challenge them. Here we go, the 3 negative beliefs. Cancer treatment is worse than the cancer itself. They're really not. They're better than ever. They're improving all the time. I had a lovely gentleman in his 90s some time ago, and he was found to have cancer. And there was war. I mean, there was war, and the family were hopping mad that I had tested him. They were hopping mad that I had referred him. They didn't want him to have any treatment. Eventually, they went down. I think he got an infusion once a week and he took a tablet every day. It was fine. The treatment was fine. And actually he felt much better and they were very glad in the end. It's not what it used to be. I would not want to know if I had cancer. You do want to know, and the sooner you know, the better. Diagnosis of cancer is a death sentence. Over 200,000 people in Ireland now are living with cancer. And that number is going to increase more and more all the time. It's not a death sentence, not at all. The next slide, please. That's more or less me done. I just want to let you know about some of the resources. These are available on healthpromotion.ie. There's some very nice posters. You might want them to put up on your wall or on the front window, or just to hand out to people, or you may want them for your own use. They're available on healthpromotion.ie. You can order them. They'll be delivered to you free of charge. Next slide, please. We also have an HSE Land program on reducing your cancer risk. If you want to know more about the things that we can all do to reduce our cancer risk. And the next slide, please. Finally, we have the Early Diagnosis of Cancer e-learning program on HSE Land, which covers a lot of what I covered here tonight, but kind of goes into more detail about it if you want to get some extra CPD points. And the next slide, please. And that's me. Thank you all very much. And thank you, Grace, again, and Michelle for hosting us this evening.
Thanks a million, Luna and Margaret. That was really informative, really excellent. Feel free to pop some questions into the chat if you like. At the moment, we just have the one so far. I think, Luna, maybe for yourself, and just wondering, what do you mean by changes in urine?
Yeah, you're right. And I should have said that. It's nothing to do with the color or anything like that. It's a change in frequency of passing urine, or unable to pass urine, or I suppose obviously passing blood in the urine. That's what's meant by change. So unable to pass urine, a change in your frequency, or passing blood. And obviously passing blood anywhere really should be checked out. So be it blood in your urine, blood in the bowel habit, coughing up blood, vomiting up blood, or bruising, bleeding anywhere you shouldn't be bleeding, needs to get checked out.
Okay, great, thank you. Another one there, why is cancer so prevalent in Ireland? Is it to do with lifestyle or something else?
Oh, do you know what? It's not that we're more prevalent than anywhere else in Europe. It really isn't. Certainly, they reckon in the World Health Organizations that 30 to 40% of our 40 to 50% of our cancers could be prevented if we all changed our lifestyle and changed some of our behaviors. But actually, really, they do think that some of it is down to lifestyle, but some of it is down to the fact that we are all living longer. And our population is expanding as well. Our population is now 5 million. It's growing. But there are some changes in some cancers. I mean, one of the stranger ones, more curious ones, I suppose, and it's certainly worth a mention, is the change in colorectal cancer in the young. That would be colorectal cancer in people under the age of 50. So 30 years ago, we would say 6 cases per 100 were in people under 50. Now it's 10 cases per 100. It was 6%, it's now 10%. And that's a worldwide phenomenon, in the Western world anyway, an increase in colorectal cancer in young people. And they think that that's down to lifestyle and down to a Western diet. Nobody's really entirely sure, but that's the theory at the moment, that it's the Westernized diet and the Westernized lifestyle. We're seeing this increase in young colorectal cancer. And again, it's just one of those ones to watch out for. You're never too young. Never, unfortunately, never too young.
Yeah. Patricia's just saying there, super talk, thank you so much. I've one final question, if that's okay, just around if things are caught at stage 1, then those survival rates are so high. Are there always symptoms at stage 1? Are there always non-specific symptoms, or in hindsight, is it that there was absolutely nothing could have told you?
No, they vary from one cancer to another. That's very true. And actually, prostate, I put up a slide there saying that the rate of detection of prostate cancer, for example, at an early stage, at stage 1, the rate of detection of prostate cancer is low at stage 1. But to be fair, for prostate cancer, even if you're picked up at stage 2, the survival is still 100% at stage 2. Yeah, it's fantastic. There are still some cancers that are just very difficult to pick up, and that's why I put up ovarian. Does it cause symptoms? It mightn't. People look back and say, "Oh yes, I had a twinge in my tummy," but you can't say for certain if that was it. It's ovarian is one that's difficult to pick up. It may or may not cause symptoms that you may reasonably recognize as ovarian cancer. Pancreatic cancer is another one, very tricky to pick up early.
Yeah, we've a question just in there on the pancreatic, actually. What are the signs and symptoms of that, and why is it so life-threatening?
Oh, it's so life-threatening because it's so difficult to pick up at an early stage. And most pancreatic cancers are picked up at late stage. The signs and symptoms would be tummy pain, back pain, nausea, appetite loss, all very vague and non-specific. And then as it progresses, you can present with even jaundice or new onset diabetes, but it tends to be picked up late. It's just in that part of the body where there's room for a tumor to grow quietly without causing symptoms, unfortunately, at a late stage.
Okay. A question on electronic cigarettes. What are the cancer risks for those? And it's worrying with a huge increase in use, particularly among young people. They're not banned under the age of 18. And is there scope for smoking cessation to be more widely available to the general public for free, including alternative methods such as Allen Carr?
Yeah, the smoking cessation is available to the general public for free. I don't know that pharmacists can access it. Actually, Patricia might know that, but I can certainly refer people up electronically, and they don't have to come in to see me. If cost is an issue, they can just phone me, and I can send them up by referring them on the phone. So it shouldn't have to be a case that cost will be a problem for them.
Thank you.
There is a real problem with vaping, and vaping it's just I think one of the problems with vaping is that as a health service, we have to have the HSE has to have the facts and the evidence. And while we're gathering facts and evidence, the companies are in there, the vaping companies, they're in like Flynn promoting these things and saying that they're harmless. And that takes hold. That message takes hold before any other alternative message has a chance to get a grip. About 5% of adults, about 9% of children in Ireland aged 12 to 17 will have reported using e-cigarettes in the last 30 days. You know, some of the manufacturers will say, well, vaping isn't as bad as smoking. But, you know, smoking kills half of all smokers. So there are very few things on this earth that we do that are as bad as smoking. So, right, vaping is not as bad as smoking. But again, I shudder. I can't think of anything that is as bad as smoking. There, there certainly are problems with vaping. They contain. There are over 2,000 different types of vapes out there. They contain known carcinogens. They are known to contain substances that are addictive. Some of the time, you don't know what's in them because they're unregulated. They are certainly appear to be marketed at children. I mean, I went Googling one day for types of vapes. I found Rainbow Crush. I found Strawberry something else. I mean, they're not aimed at middle-aged men and women trying to come off cigarettes. Now, that said, there is evidence that they may be helpful in coming off cigarettes, but they are no better than nicotine replacement tablets or smoking cessation advice. So they're just a no. They're just a hard no, vapes. I can't say why the government hasn't banned them or whether they're going to ban them. I am not in the government.
Yeah, absolutely. They've crept up on us. Yeah.
Like one other thing, just when you've mentioned reducing cancer risk course, you know, just there's also a really nice HC land training course called Making Every Contact Count, and it's about brief interventions about reducing those, or kind of, I suppose, trying to intervene in those modifiable risk factors like alcohol, tobacco, exercise, you know, healthy eating. Just people might find those useful as well. They're short courses, but just about brief interventions.
Yeah, great. Thanks, Margaret. I'm conscious we're running out of time. Maybe just one final question, and that came in about what kind of cancers are caused by obesity in particular.
The big one would have to be uterine cancer. And it's cancers that particularly are related to estrogen in the body. So, for example, as I say, the adipose tissue in women will make estrogen, and that estrogen causes the lining of the womb to overgrow, and that overgrowth can predispose you to endometrial, that's womb cancer. Obesity is also associated with breast cancer as well, but there's a bunch of them. There's esophagus, breast, myeloma, bowel, womb, pancreas, liver, stomach, gallbladder, kidney. So it's associated with quite a number of cancers, but they reckon in one paper I read from the UK, they reckoned it was associated with up to 1/3 of cancers of the womb, but about 23% of liver and kidney cancers, and a slightly smaller number of gallbladder cancer. Kidney and liver cancers would not be common cancers, so although it's thought to contribute to a lot of them, it wouldn't be a high number of cancers overall because the number of those cancers is quite small.
Okay. Thanks, Una. There was just a comment that for the pharmacist to have a role here, they need to be able to take the time to talk more with his or her clients or patients. And I think that's kind of an ongoing struggle in community pharmacy in particular, that the administration and everything. And if we know our patients, we need to have the time to take with them as well. But yeah, lots of comments have been that it's been a really interesting webinar. Thank you so much to you both for taking the time. I think we're at 9 now, so we might leave it there.
Thanks very much, Michelle.
Thank you both.
Thanks.
Yeah, we'd really appreciate feedback from everybody. There's a survey link in the chat box, so if you want to take a couple of moments to fill that out. And also, I suppose at this time of year, we're wrapping up 2023, so it's an opportunity to complete a reflective cycle on your practice. And yeah, we'll be back in 2024, and the end of January 2024, I think, is when the next webinar will be. So taking this opportunity to wish you all a very happy Christmas and a peaceful new year, and keep an eye on social media for the updates. Thank you so much, everyone.